The definition of urinary tract infection in long-term care facilities. Prior to the revised McGeer criteria that just came out, previously the McGeer criteria was similar to the FTAG 315, and that's what the surveyors look for when they come and survey the facilities. And basically it was, if you didn't have a catheter, you had to have at least 3 of the symptoms, which was the fever, the dysuria, frequency, urgency, flank pain, or change in character of urine, and the mental status changes. If you did have an indwelling catheter, this was also pretty similar, except for the worsening mental or functional status. A patient would have a foul odor, or maybe they were sundowning and they had altered mental status, and right away they would dip the urine and call the physician for an antibiotic. And often it's done in the evening, and it's one of my colleagues that on call, and the resident would end up with an antibiotic. So Doreen Valiquette from Union House Nursing Home put up this form that the nurses had to use. And it's basically the McGeer and the FTAG, the previous McGeer criteria and the FTAG. So, you had to have 3 symptoms if you didn't have a Foley catheter, and 2 if you had the Foley catheter. And the nursing staff was told that if they had 1 or 2 symptoms, to push fluids for at least 24 to 48 hours to try to hydrate the resident before dipping it and calling the physician. So this cut down on the usage of antibiotics. This is the new McGeer criteria, so I think you guys have heard it multiple times. And basically, it's now without a catheter or a catheter. There has to be both criteria 1 and 2 have to be present. 1 is basically the signs or symptoms, and like I said, it's the acute dysuria, the fever, leukocytosis, and at least 1 of the following localized urinary tract symptoms. And in the absence of the fever, leukocytosis, you have to have 2 or more of the localizing signs or symptoms. And what's new is the microbiologic subcriteria, and if it's not from a straight catheter, it has to be 10 to the 5th, and if it's obtained from a catheter, then it can be from 10 to the 2. Residents with an indwelling catheter, same thing. They have to have 1 and 2, and the second is always the culture. So with a urinary catheter, at least 10 to the 5th, and the criteria, they have to have at least 1 of the following symptoms or signs. I just wanted to mention briefly about asymptomatic bacteriuria. It's the presence of, as you all know, it's the presence of bacteria in urine of an asymptomatic resident. We usually call it colonization, but reviewing the charts, they say it's not really colonization. They think it's like there's a focal host response at the level of the bladder, so it's really not, that we are responding, but we just don't feel it. So they say that the appropriate term now is asymptomatic bacteriuria. In elderly long-term care residents, the prevalence varies from 25 to 50% in women, so it's pretty elevated, and 15 to 40% in men. Asymptomatic bacteria should not be treated, since multiple studies have shown that there's no benefits, including no decrease in morbidity or mortality. Treatment of asymptomatic bacteria does not decrease the frequency of symptomatic UTIs, in the sense that if you have asymptomatic bacteria or not, and you treat it, it's not that you're going to have less UTIs eventually. And it's not going to prevent from having further episodes of bacteriuria. So it's not that you treat it and then say, okay, I won't have any asymptomatic bacteria anymore since it's treated. However, antibiotics, as mentioned in the previous talks, are associated with adverse effects. And That's why we're here for the multi-drug resistant organisms and C. difficile infections. And like I said, not to talk about all the adverse reactions that these elderly patients have. Pyuria is another terminology. It's increased leukocytes in urine, or the leukocyte esterase. Now, pyuria was used before for diagnosis of UTI, and it has been eliminated, which is good, because pyuria is usually present. It is present in symptomatic UTI. So if someone has a urinary tract infection with, a true, it's usually present in the UTIs. However, 90% of these nursing home residents with asymptomatic infection, so they don't have any symptoms, can have pyuria. Moreover, 30% without the bacteria also have pyuria. That means they don't have bacteria in their urine, but when you go test the urine, they see, there's the leukocyte esterase and the leukocytes. And they say that most likely these are secondary from another source, genital, prostate, or maybe a renal inflammation. Thus, the presence of pyuria is not sufficient for a diagnosis of UTI, and I think in the McGreer it has been eliminated. Nonetheless, the absence of pyuria is very useful in excluding UTI. So if you don't have pyuria, most of the times you're not going to have a urinary tract infection. The guidelines for antibiotics, this is as per the IDSA. They recommend as first antibiotic is trimethoprim, Bactrim, and you can see by the creatinine clearance, it goes to single strength for creatinine clearance of less than 30, and it's contraindicated for less than 15. The next are the fluoroquinolones, Cipro. They recommend 250 Q12 hours. And then for creatinine clearance of less than 30, it goes down to 250 every 18 hours, and less than 10, 250 milligrams daily. Levaquin, this was new to me. The recommended dose is 250 daily. We're used to treating respiratory infections in the elderly with 500 milligrams. So I'll be honest, this was a new to me. I usually use Levaquin for UTI, but it's in the elderly, no matter, even if their creatinine clearance is greater than 60, that's the dose to treat for a urinary tract infection. And if they have a creatinine clearance of less than 20, you give it every 48 hours. Alternate therapy, if they're allergic to sulfon, they don't tolerate the fluoroquinolones or are allergic to those, the alternate therapy is Augmentin. Amoxicillin has a lot of resistance, so we don't just give the amoxicillin. We give it with the clavulanate, if I pronounced it well, Augmentin. And the 875 is not given to many of my residents because, as you see, the 500 every 12 hours is for creatinine clearance of 10 to 50. So it's rare that I don't have many residents in the nursing facilities that have a creatinine clearance greater than 50. And if it's less than 10, then we give it every 24 hours. Macrodantin, I don't think I ever gave it to any of my nursing home patients. The dose is 100 milligrams every 12 hours, but it's contraindicated for a creatinine clearance of less than 60, and it could build up toxic metabolites. So, like I said, I don't, maybe a few of the young ones that are there, but otherwise I don't use it. Then there's the cephalosporins, and it's mostly the third generation. When they have a severe infection, I like Rocephin because they don't have to go to, we don't have to put an IV because I can give it IM. So, and that I usually give a gram daily, so it's one injection if I have to use it. Vancomycin, last resort. I mean, we've talked plenty about it, really, if there's nothing else that we can give. Linezolide, Zyvox, it's very expensive. But it's a pill. It's a pill, and I think there's a liquid form, and that's 600 Q12. And for this one, there's no renal adjustment needed. So, the duration of therapy, it remains unclear for the elderly population. Like I said, IDSA is pretty clear for, the uncomplicated or complicated for young females, but for the elderly population, it's still pretty unclear. The latest geriatric syllabus, which just came out in 2013, and I just did my boards, still recommended at the time therapy for 7 days for females and 10 to 14 days for males. However, reviewing some of the articles, I saw that some studies have shown that a short course, even in the elderly female in nursing homes that have, truly uncomplicated UTIs, 3 to 6 days was sufficient. So that remains, I don't know, it's, that remains, we know the doses, we know which antibiotic, but when it comes to the duration, it's still a difficulty for me. And I base it on how sick the patient is at this point, and if they have, recurrent UTIs, and it varies. And sometimes I just give 5 days to give between 3 and 7, I'll be honest, because we don't have any data for the elderly patients. So I'd like to conclude by saying a large proportion of elderly residents are overdiagnosed and overtreated in the nursing homes. The blame is often put on the provider for overprescribing. That's why I'm here to defend the providers today. But however, we have to consider the provider's side also. And, I saw this in a slide, and it said, the provider gets a call at 2 o'clock in the morning. It's not his resident. He knows nothing about this resident. He has a nurse on the other side who's tired, and all she wants is an antibiotic, and says, Dr. Fatigati usually gives an antibiotic, so, just prescribe the antibiotic. And, and then when sometimes we question them a little bit more, they'll say, oh, family wants the patient treated. If you're not going to treat them, then you send them to the emergency room. And, we laugh about it, but it does happen, and it does happen frequently. So, my colleague is just going to give the antibiotic. And then I'll deal with it the day after. They'll call me and we'll adjust the doses. Maybe we'll change the antibiotic. Maybe we'll discontinue it. And this is, like I said, this is pretty frequent. I'm fortunate that I get to see this because, like I said, I just do facilities. So most of my patients that get urine cultures, well, not most, all of them actually, the ones that get urine cultures or that are treated, the staff from the facilities is going to come to me and say, okay, they've been treated for this and this is what we did, and most of the time I'll have the CNS back and I'll verify the dose and if it's the right antibiotic, and we make adjustments. But it would be nice that if we would have, like I said, a template, which we are going to be working on it because we're going to have to change the one that we had, and with the new McGeer criteria. And besides the updated McGeer criteria, we would put the urine dip results, but just put the leukocytes, the nitrates, and maybe the blood, have the vitals, the allergies. And this is something that I would want to put in the template, is the creatinine clearance. It's so important. I can't expect my colleagues or I to prescribe an antibiotic, and when we don't know at least close to where their creatinine clearance is. And and looking back at the study that we saw, I mean, the physicians that were prescribing, I don't think they were given the creatinine clearance. It's maybe they went by age, or maybe they went just by how we treat the young females with a urinary tract infection. So I think that's important. I think it wouldn't be too difficult to do. We usually have the gender, the age, the weight, and if they haven't had a creatinine, I don't know, in 6 months, a year, we'll get it, unless it's someone who's palliative or the family don't want further lab work or treatments. I mean, obviously, we're not going to do that. And I think it's important to have it on the chart so when they call the provider, they can tell them what the creatinine clearance is. And the other thing that I would want, which I would like to put on the form, whether it's faxed to the facility, because during the day when there's a provider, this is faxed to the clinic. Unless I'm in that facility, then they'll come up to me and show it to me. But to have actually the antibiotic, the dosage, and the duration, especially the ones that we use frequently, because like I said, even some of the doses didn't know. And just doing my geriatric, renewing my geriatric fellowship, there's so much variance that it would be nice that the provider who's covering for me or would have, even for me myself, to have that form and just click and sign it and send it back. And obviously, like I said, to have the code status, because if the family or don't want antibiotics, it would be important to know so that we don't prescribe it. I think there needs to be communication and teamwork from all parties. Like I said, you know, we put the blame a lot on the providers, but I understand them, you know, so I think it has to be a communication from staff, educate family, and saying that just because they have bacteria in their urine, we don't treat. You know, just because they're a little bit more confused in the evening because there's, you know, of their dementia, we don't treat. And staff has been pretty good, at least at my nursing homes, to push fluids. I know it's hard with the elderly, but you know what? You pass a little sip here, a little sip there. By the end of the day, you know, they take in the amount of fluid that you want them to have. So that's it. I think, like I said, it's a collaboration, and that's what we're going to have to do if we don't want to overdiagnose and overtreat UTIs in elderly nursing home patients. Thank you very much.
We've worked really hard to work with our off-shift staff on when it's appropriate to call the on-call person, knowing that they don't know the person and they're going to prescribe an antibiotic and they're going to do whatever they're going to do so they can go back to bed. And honestly, they don't know the person, so they want to go, you know, long rather than go short and have them end up being sicker than they were.
Right,
so
right.
We do a lot of work with when it's appropriate to make a 2 o'clock in the morning phone call and when it can wait. And if somebody just has a little fever and they're stable otherwise, that call can wait until you're on and you can deal with the person that you know.
And I agree. You know, we enforce that to staff, yeah. And some of my DONs are great here that are here, Paula and Doreen. I mean, it's put into staff. You do not call her. And if they do call at 2 o'clock in the morning, they're going to have to say why and you know, account for why they called. For that, I have to say staff has been great in you know, in not. But it takes education, and like I said, it resolves the problem of them not calling, but when they do call when I'm not there, it's going to end up again with maybe, you know, a wrong antibiotic or a wrong dosage. Yeah. Yeah.
Is it possible to get a copy of your template once you
yes,
perfect it?
Yes, yes.
And also
Carol,
a copy of your presentation would be wonderful.
Thank you. Yeah, yeah, Carol, I think it's good.
Form is actually in your packet, and there are 2 very similar forms. There's an SBAR form for urinary tract infections, and there is an ABC's form for urinary tract infections as well.
Carol, I don't know who to ask for this, but I was questioning, you know, I was talking with my DONs about, you know, the F-tag now is going to be different from the McGear criteria. So I was wondering, like, you know, we're getting surveyed according to that, the F-tag, and that hasn't changed. Even with the new regulations, you know, with the 2 and the 3 symptoms, Namali, that stayed the same. So I'm wondering when CMS comes and survey us now, we're going to be going according to the new McGear, and that doesn't correspond. So I don't know.
Okay. I'm glad to see everybody here, and I'm glad to be here myself. I don't have enough information about the specific differences between what's currently in the FTAG and what the concern is about, but I know that when we are surveying, we're surveying to the specifics in the FTAG. So I'd be glad to have a conversation with folks to drill down about what the specific concern is, and specifically looking in the interpretive guidance to see what are we talking about in terms of what's there that's called guidance versus what is there for the regulation, and then, you know, have a further conversation with CMS if we're really stuck with something that is clearly in conflict. So I need to ask if folks want to have a more in-depth conversation so that I can really drill down about what the exact concern is. I know that the regulations sometimes lag with new clinical findings, and I know CMS is concerned about wanting to make sure that the regulations are in correspondence with up-to-date thinking. So we need to have an additional conversation, and I don't know who I need to contact about doing that.
I'll just jump in and say that, generally speaking, remember that the McGear definitions are for surveillance, right? And the reason we have them is so that when you go back retrospectively and try to make an assessment of is this event a urinary tract infection, based on a use of standard evidence-based criteria, you have a set of criteria to use. Clinical decision-making often doesn't have the full set of details available at the time that clinical decision-making is happening. And so what we would expect, I think, is your assessment at the time that somebody is suspected of having a urinary tract infection should include assessing for localizing signs and symptoms of the urinary tract infection. It should include vital sign monitoring. It should include documenting the full picture, if you will, of what's changed and trying to identify which of those signs and symptoms are present and which are not present. There should also be an attempt to get any diagnostic testing that might be valuable, and that might include a urine analysis and a urine culture in advance, say, of starting therapy, right? Because then you have data to act on after the fact. There are some minimal minor changes in the criteria from the 1991 McGear paper defining UTI and the updated 2012 paper. One that's really large is the removal of change in the color or character of the urine as a localizing sign of UTI. And I don't really think people would disagree that there are a lot of explanations for somebody's urine to smell bad, including they had asparagus for dinner last night, right? That's not really specific enough for us to say, oh, this must be an infection. Certainly dehydration, being out in the sun, changing your medications, all of those can be reflected in changes in the character of the urine. So that as a standalone is no longer acceptable criteria. But even in the 315 tag, that by itself is not appropriate standalone criteria for defining a UTI. So I really don't think that a facility using the new definitions for surveillance and challenging their staff to capture all of the comprehensive information at the time an antibiotic start is being considered would be in any jeopardy with the regulations. I really don't imagine that to be the case. And frankly, if a facility could show a surveyor, here are the new evidence-based guidance that I'm applying in my facility, here's the paper, and here's how we're using those criteria to help with our surveillance and with our clinical decision-making around antibiotic use, I can't imagine that a surveyor wouldn't be fine with that either.
I think that Dr. Stone has captured the approach that we would be taking. I was listening to the comments about whether or not a physician needed to be called at 2 o'clock in the morning about a fever and expecting that maybe somebody might be saying, but what will the surveyor say if we don't? Again, if the decision making is based on sound judgment about the resident's condition and it's recorded in the record so that we can see the analysis and why the decision was made to wait until the morning, then that's going to be acceptable. It's when we don't see any analysis about why the clinical decision was made that then we might have a problem. So again, being able to explain what the clinical analysis is about the given situation and presenting the new findings that you might be using, those are all about the things that we're going to be looking at rather than, well, you didn't call at 2 o'clock in the morning, you waited until 7. If we know why, then chances are that's going to be perfectly fine.